Hello, good morning. I'm Dr. Saleem. I'm a family physician and endocrinologist as well. Today, I would like to discuss briefly about pheochromocytomas. Many of you must be aware of the word hypertension. Hypertension is a significant public health problem with an estimated prevalence of about 40.8%. It is a risk factor for serious health conditions like cerebrovascular accidents, cardiovascular problems, and chronic kidney disease. One of the underlying cause of the resistant hypertension is pheochromocytoma. In this presentation, I would like to discuss briefly about incidence, epidemiology, clinical features, investigations, and management of pheochromocytoma. So first of all, I would like to discuss about incidence. Basically, pheochromocytoma are adrenal chromaffin cell tumors which arise from adrenal medulla and secretes catecholamines. They are very rare tumors, and less than 0.1% of pheochromocytoma cases are responsible for hypertension. Although it's a very less prevalent ratio, but it is very important to diagnose them timely because of certain features. First of all, it can result in potential fatal hypertensive crisis in patients. Surgical removal may lead to total reversal of symptoms. To rule out malignancy, lack of long-term efficacy of medical management in this condition, and presence of underlying genetic cause. For example, 25% of the pheochromocytoma cases have underlying RAT mutation with a coincident medullary thyroid carcinoma. VHL mutation is also seen in some of the patients. If we talk about epidemiology, we can see that there is an equal sex distribution, and usually pheochromocytoma patient presents in third and fourth decade of their life. They are usually bilateral, and especially when they are in inherited form. Family history is positive in about 10% of the cases, and genetic mutation can be seen in about 25% cases of sporadic pheochromocytomas. Now, when do we go for genetic analysis? So, there are certain indications when there is a need for genetic mutation testing. For example, if the patient is younger than 40 years and having resistant hypertension, if there are multiple tumors, if there are extraadrenal masses or extraadrenal lesions, or malignancy evidence is already there. There are certain genetic syndromes associated with pheochromocytoma, like MEN2A and 2B, von Hippel-Lindau syndrome, neurofibromatosis, and some certain other rare conditions. Now, the patient comes with hypertension, with resistant hypertension. So, when we think about screening of the patient, so there are certain features which helps us to identify the case. For example, if the patient has positive family history of pheochromocytoma, there are paroxysmal symptoms, patient is young, hypertensive. If the patient is presented with an hypertensive crisis during general anesthesia, unexplained heart failure, or in the presence of adrenal incidentaloma. 15 to 20% cases are malignant, and they are characterized by local invasion and distant metastasis. Typical metastatic sites are retroperitoneum, lymph nodes, bone, liver, and mediastinum. Clinical features are sustained and episodic hypertension, palpitation, headache, and sweating. Most important presentation is with sweating, which is present in about 80% of the cases. There are certain specific features like neurological, cardiovascular, GIT, and skin. Patient can present with headaches, paresthesias, and visual disturbances, can present with palpitations, abdominal pain, or constipation, or rare manifestation is livedo reticularis. So now we will talk about the complications. If we look at the cardiovascular system, patient can have left ventricular failure or dilated cardiomyopathy if it is untreated. In case of respiratory system, patient can present with pulmonary edema. Metabolic complications are carbohydrate intolerance and hypercalcemia. Neurological complications include cerebrovascular accidents and hypertensive encephalopathy. There are certain factors which can precipitate hypertensive crisis in pheochromocytoma patients, and they are very important to be aware both by the physicians and by the patients. like, for example, straining, exercise, strenuous exercise, pressure on abdomen, surgery, tumor palpation itself, and certain drugs, for example, anesthetics, opioids, metoclopramide, tricyclic antidepressants, contrast agents, they are responsible for aggravating the condition. Now we'll come to the investigations. So 24-hour urinary metanephrines and or catecholamines. Urinary vinyl mandelic acid is a bit less sensitive. Plasma metanephrines are the most sensitive. Usual first line test is with urinary 24-hour metanephrines. If we see borderline elevation, then we will, or we are in doubt, then we will ask the patient to repeat their urine collection and will advise specifically to avoid bananas, walnuts, pineapples, potatoes, and beans. Next come the stage of tumor localization. So MRI abdomen, specifically MRI adrenal, is the ideal choice of imaging studies. Pheochromocytoma tumors are large as compared to the Cone syndrome. 98% are present in abdomen, less than 2% are present in chest, and 0.02% are seen in head. Next investigation is radio-labeled MIBG scan. It is positive in 60 to 80% of the cases. Its importance lies there when localized tumors are not detected by MRI. It's 100% specific and is performed preoperatively to exclude multiple tumors. Now come the PET scan. This is another imaging modality to diagnose pheochromocytoma. If we talk about the management, we have choice of medical and surgical. But medical management is to control the symptoms and it is done by alpha blockade, for example, phenoxybenzamine, 20 milligram every 6 hours, beta blockade with propranolol, 20 to 80 milligrams every 6 hours. Beta blockers should be given 48 to 72 hours after the alpha blockade. Definitive management is only surgery and it is curative in about 75% of the cases. Mortality is seen in less than 2% of the cases during surgery. Preoperative anesthesia management and assessment both are very important in case of pheochromocytoma. Follow-up is done with 24-hour urinary free catecholamines and the first sample should be given 2 weeks after surgery. There should be lifelong follow-up to detect any recurrence. Chromogranin A is a useful diagnostic and a follow-up marker. If we talk about follow-up for malignancy, malignant tumors require long-term alpha and beta blockers. Tyrosine kinase inhibitors help in controlling symptoms. Chemotherapy with cyclophosphamide and doxorubicin have beneficial results. Palliative radiotherapy is reserved for bony metastasis. Persistent hypertension in 25% cases is seen even after surgical removal of the tumors. 5-year survival for benign tumor is 98%, is 96%. 5-year survival for malignant tumor is 44%. SHP gene mutation is associated with short survival. So this is all about pheochromocytoma, a very short overview. Thank you very much.